Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple things before we get started. You can submit your questions via the questions panel throughout the webinar, and we'll try to get to those at the end. And your certificate will be available on Friday by logging into your account. Kristen, if you're ready to get started, go right ahead.
I am. Hi, can you hear me?
Yes.
Okay, great. Well, thank you so much for inviting me to give this presentation today. My name is Kristen Elgersma, and I'm a PhD candidate at the University of Minnesota. And today I'm planning to share some recent work that I've done on human milk and direct breastfeeding for a particularly vulnerable neonatal population, infants with critical congenital heart disease, or CHD. And I'm going to focus in some of these studies on infants with single ventricle physiology. So today I'll be talking about 4 studies, and you can see some of the objectives of this presentation up here on the slide. So these studies are going to focus on the prevalence of human milk and breastfeeding for this population, on some predictors of these feeding practices. We'll talk a little bit about how lactating parents are able to establish direct breastfeeding with these infants, and look at the impact of human milk and breastfeeding on important health outcomes for these infants. Before I dive in, I'd like to acknowledge some of my co-authors for these studies and also share funding and disclosure information. And I'd also like to start with a little bit of my personal story and why I became interested in this topic of human milk and breastfeeding for infants with CHD. So I'm a second career nurse. I have a doctorate in piano performance, and I was a pianist for many, many years. But in 2015, my first child was postnatally diagnosed with critical CHD. And this is Indy up here on the slide. So this was very unexpected and pretty traumatic, particularly when he underwent open heart surgery at only 1 month old. But I sort of unexpectedly found the healthcare side of the whole process absolutely fascinating. Unfortunately, there were several factors that prevented Indy and I from establishing a direct breastfeeding relationship. We were separated after birth. There was a lack of cohesive support from the healthcare team. I remember a cardiologist warning me that he'd probably have trouble feeding and gaining weight, which absolutely did not turn out to be true. He was very, very chunky. And I was also a first-time mom, and I just didn't have any idea what I was doing. So I ended up pumping for him exclusively for a year. And I was happy to provide human milk, of course, but I did regret not having that experience with him. And I realized upon meeting and talking with a lot of other heart moms, as we call ourselves, that my experience was unfortunately common. I felt like there were assumptions made about his capabilities that ended up not being true. And with just a little bit more support, we should have been able to directly breastfeed. It was really a missed opportunity for care. So I decided to change careers and focus on contributing to research in human milk and breastfeeding for these infants. And today, as I mentioned, I'd like to share some results from 4 recent studies I've done in this area. But first, a little background, especially if you're not familiar with the CHD population. Why is this important to study? Well, CHD is the most common birth defect, and infants with critical CHD, in which they really need an intervention or a surgery within the first year of life, are some of our most vulnerable neonates. These infants often have multiple childhood surgeries, which contribute to them having the highest hospital costs among birth defects. These infants are also at risk for morbidity and mortality. For example, a very serious disease called necrotizing enterocolitis that has 25 to 29% mortality rate in this population. Families of these infants experience very high stress related to feeding. They consistently rank feeding the #1 cause of concern, even above the cardiac condition. And we know that for other neonatal populations, like preterm infants, Human milk is protective against diseases like necrotizing enterocolitis that I just mentioned and helps optimize health outcomes. But unfortunately, as in my personal story, there are many barriers to human milk and breastfeeding for these infants. And so far, there's been pretty limited research in this area. So considering that there is this kind of gap in evidence and the fact that no previous studies on human milk and breastfeeding for these infants focused on the parent's perspective, we began with a qualitative study asking the question, given all of these barriers, how are parents of these infants able to establish direct breastfeeding? What all is involved in this process? For this first study, we recruited 30 participants from 26 hospital systems across the US. And these were parents who had been able to breastfeed their child with critical CHD within the past 3 years. So you can see that 57% of the infants in this study had single ventricle CHD, which is considered to be the most severe form of the disease. And I'll talk about this form of disease a little bit more in a few slides. Our sample did have some limitations of homogeneity in race, ethnicity, education level, and income. And this is a common issue in breastfeeding research, particularly as there are well-documented differences in rates of breastfeeding associated with social determinants of health. But we interviewed these participants and taking a grounded dimensional analysis approach, which is a type of grounded theory, we found that for the lactating parents in our sample, the core process of how they established direct breastfeeding with their infant was one of wayfinding through the ocean of the great unknown. And this is the kind of visual figure of how this process happened. I'm going to talk about each piece of this figure in a minute, but I wanted to start with a quote that sort of sums up this wayfinding process. This is a parent who said, "I felt like I'd been sort of thrown into this ocean of the great unknown. I just wanted my baby to be okay, and I just wanted the healthcare team to tell me what to do. I think in the beginning of our adventures, we're so fixated on, please, someone give me a map showing me the way out of this. Show me at least the first step. Where do I go? What do I do?" So this wayfinding process was characterized by 3 main sub-processes, and you can see these in the blue boxes. The first one was navigating the relationship with the healthcare team. And this is where parents had to manage conflicting priorities about breastfeeding and handle messages from the healthcare team about feeding. And we'll talk about those in a little bit more in depth in the next slide. The second sub-process, was protecting the direct breastfeeding relationship. Parents had to advocate for what they needed to breastfeed. They had to seek knowledge. Sometimes they relied on an ally in the healthcare team, and sometimes they even went against the recommendations of the healthcare team related to breastfeeding. And third, doing the long, hard work involved sort of those technical things like building and maintaining a milk supply, working on the infant's oral skills, and persisting even though, as one parent put it, it felt impossible at times. There were also influencing conditions up there in the gold. The most important one was a relentless concern about weight gain from the healthcare team that really interfered with the direct breastfeeding relationship. And so we don't have time to walk through each of these in detail, but I wanted to highlight a couple examples of how parents experienced these sub-processes and how these sub-processes were related. So first, in navigating the relationship with the healthcare team, these parents described sort of a dawning understanding that direct breastfeeding and, by extension, the parent-infant relationship was often not a priority of the medical system. Rather, parents perceived that the healthcare team's primary concern, as one parent put it, is to preserve the function of the human body. And you can see this in the quote on the right. This parent said, "The cardiologist, a surgeon, is just thinking of getting them to surgery. But this child is hopefully going to have a whole life after the surgery that I want to prepare for." This parent said, I didn't want to have regrets that I didn't have the time I wanted to have with him because I got stampeded by the agenda of someone that's just looking at the one next step. Navigating the relationship with the healthcare team also involved handling sometimes hundreds of feeding-related messages from the healthcare team. As in the case of the parent quoted on this slide, the majority of these messages were negative and unsupportive. As this parent said, the head cardiologist actually told me that breast milk was going to be bad for my baby, not because she had any allergies or intolerances, but that was just his belief. Nobody else agreed with him, but since he was the head cardiologist and the director there, it was his choice. And so then this parent used some strategies to protect the direct breastfeeding relationship. As they described it, I actually started doing my own research, finding peer-reviewed journal articles, and found that it was good for her. And I came to him with all this information, and he still forced formula for 2 weeks. And then I switched it once she was no longer under his care. And I just wanted to remind you too, this is within the last 3 years that this happened. We think maybe an understanding of the benefits of human milk for vulnerable neonates would be kind of understood by everyone at this point, but this happened within the last 3 years. So you can see that this parent that I was just talking about, in response to the unsupportive messages that she received, tried to protect the direct breastfeeding relationship through advocating and seeking knowledge. And a little later in the story, the same parent went on to say, I had an occupational therapist who was the only reason my baby was allowed to latch after her first surgery. Because she pushed and pushed, she showed her face to the doctors every single day, asked every single day to allow it to happen. I was about ready to hide behind a curtain and do it myself. But thankfully, I had allies in the hospital to advocate for me and my baby. So this parent ended up relying on an ally in the healthcare team and was ready to take that final step of going against the healthcare team. And this final step was not uncommon. Many parents described feeling like they had no other option but to hide breastfeeding from their team. This going against the team often happened after sort of a persistent reluctance on the part of the healthcare team to support breastfeeding in a way that was acceptable to the parent. As in the case of this parent quoted on the slide, who said, they had us on a formula that was making her really, really sick. We were telling her, they were like, just keep doing it, keep doing it. But finally, me and my husband decided, we're not doing this. You don't understand. You don't see her in pain. You don't wake up in the middle of the night to her face completely blue. You aren't here. So we're doing complete rest. So this was generally not a comfortable process to go against what the healthcare team asked of the parents. The parents wanted to do the best thing for their child. And so parents often just didn't tell the healthcare team what they were doing. But this strategy was essential to protect the direct breastfeeding relationship in many cases. So finally, parents described engaging in this technical work that I mentioned to build and maintain their milk supply, pumping day and night, to build their infants' oral skills, using a lot of strategies that are similar to those that have been described for preterm infants. If you're familiar with the SPATS 10-step model, a lot of those things were described by our parents. Doing oral care with human milk, skin-to-skin contact, non-nutritive latching at an empty breast, slow incorporation of nutritive breastfeeding, and test weights pre and post breastfeeding to track volume. And I also wanted to highlight that, as in the quote on this slide, the infant's first latch directly at the breast was universally described as a pivotal experience. This parent said, this one little moment can change your whole perspective. She said, I had a really hard time wanting to try to bond with my child because you don't really know what's going to happen. And you're like, if I fully invest into this child right now, and then they're taken from me, I don't know how I'm going to actually be able to move on with my life. But it's like once you take that leap of them feeding from you, it's an eye opener. It's a game changer for sure. So you can see this wayfinding process was very important and very meaningful to parents. Feeding their baby was about much more than just providing nutrition. Many talked about how breastfeeding was the one thing that they could hold on to, the only thing that was sort of normal, and gave them hope for a future that would be a less acute, more typical childhood experience. So one of our major takeaways from this first study is that, as in the quote on this slide, it's clear that parents were overwhelmingly not getting the support needed and that the evidence base was not sufficient in this population. And therefore, it was not a priority for the healthcare team. If you're interested in learning more about this study, it was published in Cardiology in the Young, and you can find it there. But now I'm going to move on to our next step. So we next addressed this lack of evidence through 3 studies that were focused on human milk and breastfeeding for infants with single ventricle CHD. And that's when one ventricle is missing or underdeveloped, one ventricle is undeveloped or missing a valve. And it's, as I said, considered to be one of the most severe forms of CHD. So the 3 studies I'm going to talk about next were all analyses of the National Pediatric Cardiology Quality Improvement Collaborative Registry, or NPC-QIC. And this is a collaborative of 68 pediatric cardiac centers from across the US. And there were around 2,500 infants in this registry, which is really amazing because this is a rare disease. Sometimes sites have just a few infants per year. So to be able to do any kind of study, we really need this kind of large collaborative of data. And we looked at data from 2016 to 2021. So I wanted to take a quick moment and be sure we're all on the same page with some of the abbreviations that I've been saying and that you might be seeing. But also I wanted to mention that if you're not familiar with single ventricle CHD, these infants typically undergo 3-staged palliative surgeries or interventions during childhood. In the work that I'm going to talk about today, I'm going to focus on time points related to the first 2 of these palliative surgeries, the stage 1 palliation, which usually happens in the first week or so of life, and the stage 2 palliation, which usually happens at around 4 to 6 months old. So you'll see time points related to stage 1 or S1P and stage 2 or S2P. So in these studies, we had 3 aims. The first was primarily to establish foundational baseline evidence about the prevalence of human milk and breastfeeding for these infants. The second was to identify supportive and limiting factors. And the third was to look at the impact of human milk and breastfeeding on outcomes for these infants. And I'm going to focus mainly on the last 2 aims today, because we used some analytical approaches that, to our knowledge, hadn't been previously used in congenital heart disease feeding research. Machine learning for the second aim, and propensity score matched analysis for the third aim. And we'll talk about those a little bit more down the road. So to start with aim 1, we needed foundational evidence to know where we were starting. How many of these infants were actually receiving human milk and direct breastfeeding? So there were 2,491 eligible infants in the NPC-QIC registry, and I'll point out a couple of details about our sample. About 40% were female, 71% white, over half had government insurance, and only about half received enteral feeding before the stage 1 surgery. And this could be due to clinical reasons. Maybe the infant was too unstable to feed, or maybe they went right to surgery and really didn't have a preoperative period. Or it could be due to institutional practice. There are institutions still that don't feed infants before surgery as a standard practice. And that used to be kind of standard practice everywhere, but that's been changing over the last decade or so. So in this study, we did establish the prevalence of any human milk feeding, exclusive human milk, any direct breastfeeding, and exclusive direct breastfeeding at 4 time points during the first 6 or so months of life. And I know there are a lot of time points and percentages on this page. So basically what you need to know is that, as expected, human milk and breastfeeding rates are much lower than global and national recommendations, or than the US population average. For example, only about a third of these infants had any human milk at the time of the stage 2 surgery, at around 5 months old. We can compare that to the US population, which has 56% of infants having any human milk at 6 months old. So 37% at 5 months old versus 56% at 6 months old. And less than 10% had any direct breastfeeding at this time. Another thing that we noticed is that there was wide variation in prevalence depending on the hospital or the NPC-QIC site. So in this figure, each of those columns is one site, so one hospital. The yellow is the prevalence of any human milk feeding at that particular site, and the purple is the prevalence of any direct breastfeeding at that same site. So for example, in that first panel there, the stage 1 palliation pre-op time, you can see that the prevalence of any human milk feeding ranged from 0% to 100%, depending on what site the baby was at. And that really raises the question, why are some sites doing so much better than others? But it also indicates that we do have potential for a lot of population level improvement. If we can figure out what's working well at some sites, there is potential to implement it nationwide. So if you'd like to learn more about this study, these results were recently published in Breastfeeding Medicine. But essentially, after we determined that yes, as expected, the prevalence of human milk and breastfeeding are low in this population, we were still left with the question, what are the predictors of human milk and breastfeeding for these infants? And that's what we focused on in our second analysis. So for this study, we looked at 3 outcomes of interest: any human milk, exclusive human milk, and any direct breastfeeding at the 2 time points on your screen, at the first hospitalization discharge and at the time of the second surgery. So our methods for this analysis involved a multi-step process using a machine learning approach. I won't get into too many details about this, but essentially, in case you're interested, we used multiple imputation for the 1.2% of data that were missing, and then used a couple of rounds of elastic net logistic regression to determine what were the significant predictors of human milk and breastfeed. And one reason we used this is that we had 90 potential factors, things that we thought could influence human milk and breastfeeding. And elastic net logistic regression really helps us sift through the noise and see what's really important. That's really where this method shines. So what we found is that variables that were identified as significant predictors were most frequently in 5 domain areas: preoperative feeding practices, demographics and social determinants of health, the feeding route of the infant's clinical course, and their sites, the NPC-QIC sites. So this figure provides an overview of all of the significant results for the S1P, the stage 1 surgery discharge time points. And I'm going to point out some individual predictors in the following slides, but I wanted to kind of acclimate you to this visualization first. So the x-axis of each of these panels is the odds ratio. And when you're working with odds ratios, anything above 1 is support. For example, an odds ratio of 2 means that an infant is about twice as likely to be getting, for example, any human milk at discharge. And you can see there's a vertical line there at 1. So anything right to the right of that line is a supportive predictor, while anything to the left of that line is a predictor. Those larger colorful circles indicate how important the variable is. So the bigger the circle, the stronger the predictor. And there are a lot of predictors on this page, but I want to highlight a few results. So first, the preoperative route and type of nutrition were significant. So you can see there, the first one on the left, preoperative breastfeeding, infants who were preoperatively breastfed had were about 2 times likely to have any human milk feeding at the stage 1 surgery discharge. But bottle feeding, whether with human milk or with formula, was negatively associated with later human milk or breastfeeding. Secondly, variables related to demographics and social determinants of health were frequently significant. Economic indicators appeared most often, and with private or self-pay insurance and higher area median income associated with higher odds of human milk and breastfeeding. Black or African American infant race was associated with lower odds of any human milk compared to white infants at both time points, but race was not a predictor of direct breastfeeding at either time point. Variables related to an infant's clinical course were significant, but they tended not to have the highest variable importance score. They tended not to be the strongest predictors, with the one exception of stage 1 palliation length of stay. That was a strong predictor in the model. In the analyses for the stage 2 surgery time point, we found similar patterns of results. And you can see there are some particularly strong supportive predictors out on the right there. And they pretty much all relate to breastfeeding as the route of feeding. For example, infants with any breastfeeding at S1P discharge had much higher odds of any human milk and any breastfeeding at the subsequent stage 2 surgery. Makes sense. If you're not breastfeeding at stage 1 discharge, you're probably not likely to start doing it between stage 1 and stage 2. There was also a lasting potential impact of preoperative breastfeeding. And this, to me, is particularly striking, considering that pre-op time averaged only 6 days long. But infants who breastfed preoperatively were about twice as likely to still be receiving any human milk at the stage 2 surgery around 5 months later, and about twice as likely to be directly breastfeeding at that time. Additionally, if you remember back to that figure showing the variation in prevalence among NPCQIC sites with the purple and the yellow columns, it seemed pretty likely that what site you were at would be an important predictor. And so we tested this and found that it was true. Site was a significant predictor of human milk and breastfeeding, especially at the stage 1 palliation discharge. And if you look at this figure, you can see the odds of each feeding practice at each site. Each of those little dots is one site. And what stands out is that some sites there have essentially 0 odds of these feeding practices around here and around here, while other sites have strikingly above average odds up here, up here, up here. So once again, if you'd like to learn more about this study, this paper just came out in the Journal of Pediatrics this past week. So you can see more details there if you'd like. And I want to just pause here for a quick moment, because I know I've thrown a lot of information and figures and numbers at you, and take 1 second to reflect on a few key takeaways from these last 2 studies. So first of all, as we just saw in the machine learning analysis, preoperative feeding practices, and particularly preoperative breastfeeding, have lasting potential impact on the future nutrition of these infants. And that really indicates that interventions to increase the low rates of human milk and breastfeeding in this population should focus on the preoperative and prenatal times. Parents need to be ready and make an informed choice about how they want to feed their infant right away from the start. Secondly, similar to research in preterm and healthy populations, we found significant health disparities in which not all families have access to the resources needed to establish and maintain human milk feeding and breastfeeding. And this is a complex issue with both systemic and individual causes. But on a clinical level, those caring for infants with single ventricle CHD must address individual and institutional bias that could contribute to these feeding disparities. For example, there are qualitative studies that have documented consistent race-based discrimination by those providing lactation care, with providers both consciously and unconsciously offering patients of color lower quality care and less frequent support. Additionally, the wide variation in human milk and breastfeeding, as I've mentioned, suggests that there is an opportunity to improve human milk and breastfeeding prevalence in this population. And we know some of the institutional practices that support human milk and breastfeeding in preterm infants: skin to skin, a multidisciplinary approach to lactation support, etc. But there's been limited research into these practices in the CHD population. And this is an opportunity for future translational research and QI work. So moving on to our last study. So we've established the human milk and breastfeeding prevalence for these infants. We've identified supportive and limiting factors. And so the final study that I'm going to talk about today sought to estimate the effect of human milk feeding and direct breastfeeding on key health outcomes for these infants. If we do find ways to improve the prevalence of human milk and breastfeeding, what will be the result? So once again, we examined 4 stage 1 and stage 2 time points. And the feeding groups and outcomes that we analyzed at each time point are outlined in this study diagram. We focused mainly on necrotizing enterocolitis, sepsis, time to full feeding volume, and hospital length of stay at both stage 1 and stage 2 surgeries, on infection, hospital readmission, and mortality. And you can see there we looked at a lot of different feeding groups and comparison groups as well. At the preoperative time, during the stage 1 hospitalization, during the interstage time between the 2 surgeries, and then during the stage 2 postoperative time. So in this study, our method of analysis involved using propensity score matching, and I'll share a little bit about what that means. So propensity score matching is a method for causal inference. You may have heard correlation does not equal causation. And propensity score matching is one way to kind of move beyond that correlation and be able to say, we think, for example, human milk feeding was the cause of this good health outcome. And this is especially helpful in breastfeeding research. It's really impossible to randomize infants to breastfeeding. It's unethical. We can't do it. And so this is a really good way of addressing some of those limitations. And so the way the propensity score matching works is that you calculate a propensity score for each infant, and that reflects their propensity to, for example, be breastfed. And then infants are matched. So one infant with this propensity score of breastfeeding who was breastfed, and an infant with a similar propensity who was not breastfed are compared, and their outcomes are compared between the 2. And I just wanted to note, this is a really complicated population. There are so many factors that can impact outcomes. So we included many variables that could potentially impact the outcomes for these infants in each propensity score to kind of adjust for everything that could possibly make a difference. And so what we found is that all outcome estimates at 4 time points during the first year of life were better in the high human milk and breastfeeding groups. And there were many statistically significant results and substantial clinical significance across the board. I'll give you a brief overview of some of these statistically significant results, which, as you can see from the slide, include substantially reduced odds of necrotizing enterocolitis, sepsis, and infection. For example, infants with exclusive human milk in the preoperative time had 63% lower odds of preoperative necrotizing enterocolitis. Similarly, infants in the high human milk group postoperatively had 72% lower odds of postoperative necrotizing enterocolitis. And that was a kind of interesting one because I think a lot of attention is paid to preoperative necrotizing enterocolitis, but we actually had much higher rates of postoperative NEC. I think it was about 13% postoperative versus 2% preoperative in the whole population. So postoperative NEC is a real concern. Over on the right side, 71% lower odds of sepsis related to high human milk in the S1P postoperative time. And on the bottom there, 93% lower odds of post-op sepsis related to high breastfeeding. And length of stay estimates at both stage 1 and stage 2 palliations were also significantly lower in the high human milk and breastfeeding groups. And you can see some of the ranges of reduction here. But in case you're wondering how these percentage reductions translate, that 25% reduction in stage 1 palliation length of stay on the left side of the slide corresponds to a reduced length of stay of 12.84 days. So this is a substantial magnitude of effect, and it has major implications for cost savings for families, hospitals, and payers, and also for the future development of these infants. Length of stay, being in the hospital, is one of the major risk factors for poor neurodevelopment of these infants. And so getting them out of the hospital faster is good for many reasons. So you might think, reducing length of stay by 12.84 days seems too good to be true. How could this possibly be? I wanted to take just a minute and talk about some of the mechanisms that can explain these findings. And some of these are on the slide. For example, infants with CHD are at high risk for gut microbiome dysbiosis or dysfunction due to systemic inflammation. They all get antibiotics. Formula fortification is common. And all of these things can cause gut dysbiosis. And this dysbiosis can then contribute to translocation of pathogenic or bad bacteria into the intestine to cause NEC or into the bloodstream to cause sepsis. In recent years, there has been increased focus on the cellular, molecular, and nutritional composition of human milk and on the relationship between human milk and the infant gut microbiome and immune axis. For example, we know that human milk oligosaccharides contribute to probiotic bifidobacterium colonization of the neonatal gut, and that's protective against diseases like NEC, necrotizing enterocolitis. Unfortunately, while this is a pretty hot topic in preterm research, there is very little evidence in this area in the context of CHD, and a lack of understanding in general about mechanisms of human milk and the microbiome in the CHD community. And so this is an important area for future research. But these things that I've mentioned, this gut dysbiosis, give one partial explanation for the shorter length of stay. If infants are having less gut dysfunction in their gut microbiome due to human milk and breastfeeding, and then getting less necrotizing enterocolitis, sepsis, and infection from pathogenic bacteria, they're likely to be released from the hospital sooner. That's sort of a causal pathway between those things. So if we revisit the objectives from the beginning of the slide, we've talked about the prevalence of human milk and breastfeeding for these infants and determined that it is lower than global and national recommendations and lower than the United States average, but does vary widely among institutions. We've determined that the strongest predictors of human milk and breastfeeding in this population are in the areas of preoperative feeding practices, demographics and social determinants of health, the route of infant feeding, the infant's clinical course, and the institutional site. We talked about how the process of establishing direct breastfeeding relationship with these infants is one of wayfinding through the ocean of the great unknown. And it involves navigating the relationship with the healthcare team, protecting the direct breastfeeding relationship, and doing the long, hard work. And we've talked about how human milk and direct breastfeeding do improve health outcomes for these infants, including reduced odds of necrotizing enterocolitis, sepsis, and infection, and with shorter length of stay at both stage 1 and stage 2 palliation. But to sum up, I really think the major conclusion from the research I've presented today is that there is a critical need for improved condition-specific lactation support to address the currently low rate of human milk and breastfeeding for infants with critical CHD. We've seen that they have low rates, and as I mentioned, there's a real opportunity to do more QI and translational projects. I think I saw the first QI project published in this area recently in the Journal of Pediatrics within the past couple of months. But particularly considering the results of our propensity score matched analysis, it appears that increasing the dose and duration of human milk and direct breastfeeding has a strong potential to substantially improve the health outcomes of these vulnerable infants. And another area for future research, which we really need more information on, is so increasing the dose and duration in preterm infants has generally proven to improve health outcomes in a sort of linear way. But we have registry data in these studies. This is a large population overview. We don't have specific dose information. We don't have granular feeding practices, and these can vary so widely between infants. So that's another really important area for future research, to get really detailed about what these infants are being fed and how it might impact outcomes in a dose relationship, dose duration relationship. So with that, thank you so much for listening to my presentation today, and I welcome any questions.
Thank you for presenting that, Kristen. It was great information. We do have about 15 minutes or so for questions and answers, so we'll jump right in. You can submit your questions via the questions panel, and we'll try to get to all of them that come in. The first question is regarding the route of regarding the route of feeding, were infants receiving feeding by a tube considered? Some infants unable to feed orally receive maternal breast milk for long periods of time. This was addressed in the post-op complications and LOS. Was support for these mothers explored?
Can you repeat the question one more time?
Sure. Regarding route of feeding, were infants receiving feeding by tube considered?
Yeah, so if you're talking about the last 3 studies, the MPC-QIC registry, anybody who was receiving human milk by any route were included in those studies. So everybody with tube feeding was involved. In the qualitative study, we also had many parents who were feeding by both, I'm going to see if I can go back here, by multiple methods, feeding tube, G-tube, NG-tube, bottle, like everybody was kind of doing multiple methods, and breastfeeding was usually one of many. I'm going to see if I can go back to this slide here a second. Um, so right here, you can see at the bottom, other feeding routes used. 77% used a feeding tube at some point. 90% used bottle feeding at some point. I hope that answers the question.
Okay, thank you for that. A couple people are
Mhm.
asking, is donor milk included as human milk?
Yes, it is. We have no way of determining whether donor human milk and or maternal human milk were, what type of human milk it was in the MPCQIC registry. They don't track that. So that is definitely another very important thing to test in the future, and particularly, I know there's been a lot of studies in preterm populations uh, showing that even the volume of maternal human milk is more important than the type of fortifier, whether it's donor human milk-based fortifier, or bovine-based fortifier. So that would be another important thing to explore in this population.
Thank you. The next question
Mm-hmm.
is, have you done any research on oral immunotherapy or oral cares
Mm-hmm.
with express breast milk for patients who are intubated or not able to feed by mouth?
Yeah, so that's another great question. As far as I know, there haven't been any studies on this, or there have been a couple studies on this. Let me change that. There was one study that was more about like an oral stimulation exercise, and did not show any difference between infants receiving that type of oral care and others. And then there was a study from China that showed some benefit of oral care with colostrum versus saline, I believe. But there hasn't been much done in this area. So yet another area that we could do more in. And the NPCQIC registry does not track oral care with colostrum either.
Sounds like there's a lot of opportunities to do more research.
Mm-hmm. Yes.
The next question is, can you briefly expand on what is constituted as high BF/BM? Does
Yep.
exclusive BM include fortified mothers or MBM or no?
Yeah. So that's a great question. And of course, in a registry, we're going to be a little bit limited as to what we can have. I'm going to go back to the study design. So for the human milk groups, we had time points where human milk and breastfeeding were tracked at during the S1P time. So it tracked every type of nutrition that they got during the preoperative time, at the stage 1 discharge, and at the stage 2 palliation. So we just had really 3 time points. And so, of course, we're getting a broad overview of what these infants are getting. So what we did here during the stage 1 hospitalization is we created feeding groups based on the time points that we had. The high human milk were infants who got exclusive human milk during the preoperative time and were still getting any form of human milk at discharge, to kind of say, okay, they've been getting human milk probably during the whole hospitalization. The low duration, they could have gotten any type of preoperative feeding, even exclusive human milk, but they were no longer getting human milk at discharge. Now, we don't know when that drop off happened or if it happened, but those are the comparison groups that we could do. And it was really similar with the high breastfeeding duration. Any preoperative breastfeeding and still any breastfeeding at discharge, and any type of preoperative feeding, but no breastfeeding at discharge. And so that's kind of what we did during the interstage time as well, a similar, look at the 2 time points. And then in the preoperative time, we had more specific information on whether they got exclusive or not exclusive. Now, with Fortifier, that's another question. We didn't have good details on what was happening with Fortifier. We had a calorie recommended at discharge, so we could kind of guess if they were recommended to have 24 calories per ounce at discharge, that they were getting some kind of Fortifier. But we don't know what, and we don't know how. And I will also say 93% of these infants were recommended to have 22 kilocals or higher at discharge. So most infants were probably fortified. So, exclusive human milk after the S1P discharge, that's kind of why we didn't really look at it too much. It's really hard to say, was it exclusive? Were they fortified? Were they not? So again, I think that's why we need some of that more granular feeding data to look at these things.
Okay, thank you. The next question is,
Mm-hmm.
thank you for all this important research. In this last study you presented, how did you control for
Mm-hmm.
severity of illness in your analysis
Mm-hmm.
on the relationship of breastfeeding and short length of stay? And then there's a second part. Do you think the infants who were healthier or more hemodynamically stable were permitted to breastfeed more frequently?
That's a great question. So we used, in our propensity score matched analysis, we feel like we really controlled for severity of illness with multiple factors. We had ECMO usage in there. We had length of intubation. We had, I can't even remember all of them. I should have written them down, but we had, probably 15 variables related to the infant's clinical course that all went into the propensity score matched analysis. And I'm happy to send those to anybody if they want the details. We also had variables related to theoretically how much support that their parents could have gotten for example, direct breastfeeding. We had variables related to whether the parent, there was a variable like whether the parent got comprehensive postnatal and prenatal support, which kind of indicates, if the parent was even available to directly breastfeed their child. So we really feel like we did as much as we possibly could to minimize some of those differences. And those infants, those two groups should be very, very well matched in all of those areas. And I'm forgetting the second part of the question now.
I actually clicked off of it, so I don't see it, but
Oh, that's okay.
I can certainly get that to you and you can answer it afterwards.
Okay.
Not a
Thanks.
problem. And
Yeah.
the details that you said that you would offer everyone if they wanted
Mm-hmm.
them, you can forward
Yep.
those on to me and I would be happy to send those out to everyone.
Okay. Yeah. Sounds
Afterwards,
good.
because someone did ask for those as you were responding. So
Yeah.
there is interest.
The preprint. I will say too, there's a preprint of this study available, and so you can see all the details of our matching strategy and everything that we use as a preprint. So I can share that link.
Perfect. The next question is, during your literature review and your research, did you find any studies related to breast milk fortification and effect on gut health, neck, and sepsis?
Only in preterm infants, not in infants with congenital heart disease.
Okay. The next question is, any thoughts on how to use donor milk to support direct feeding for these and other diets?
Yeah, I think that's a great question. That's something that really hasn't been explored. And I was talking with it a little bit with some of the healthcare team at my site. The babies at the site where I am, they go to the NICU preoperatively and then the CDICU postoperatively. And so the NICU has a large donor milk program, but I think that it's typically used until the preterm babies are a certain age. I'm not sure exactly when it is. And so then, most, like the majority of CHD babies, it's just kind of a similar number of preterm. I think it's like 10 or 12% in the NBC QIC registry are born preterm. And so the question is, okay, so then do they qualify for donor milk? Is there a policy in place to support that? And I don't know at our particular site whether that there is or whether it's falling through the cracks. And I suspect that that might be similar at other sites. So I know that there is a paper by Kateria Hale from maybe 2020 or 2019 at Texas Children's, where they did a big project to increase the use of human milk in their unit. And one of their strategies, I believe, was using donor human milk, and they got to a 100% human milk prevalence with no formula usage. So I think that's really an important thing to explore as a bridge to kind of help support and uh, help parents along while they're establishing their milk supply.
Okay, thank you. The next question is,
Mhm.
what types of support are you encouraging for CHD mothers specifically? Is it different
Mhm.
than NICU mothers?
Yeah, so it's interesting. I think that the NICU culture has a strong culture in general. I mean, depending on your site, of course, but in general, the NICU culture is very human milk and breastfeeding supportive because that's been well established as a means of reducing necrotizing enterocolitis, in multiple studies over the past 4 decades. And so I think that one difference that I have seen in my work with parents is that there's not the same kind of culture of support of human milk and breastfeeding in the CHD community more broadly. So one thing I really have had to do is encourage parents that they are probably going to have to be their own advocates. And if this is something that they want to do, they might have to be prepared to get pushback and to find ways to work with their team and find people who will help support them as it's clinically appropriate for their child. Um, so I think, and I think also what I found is that prenatally, these parents are not really getting a lot of information about human milk and breastfeeding because there is a lot to talk about and a lot of concerning things regarding the cardiac condition. And so that usually takes precedence. So I think preparing parents for and just kind of giving information about the potential benefits for their infant and what it's going to look like and what it's going to feel like to be starting out this journey in a NICU or in a ICU setting where they're pumping is actually an opportunity that we have that we don't always have with preterm infants because many of these infants are diagnosed prenatally, and so we can take some steps to help support parents along the way. But yes, in general, I feel that they need to be better prepared to advocate for themselves and to find allies in the healthcare system.
Okay, thank you. We're getting close to the end. I'll try to squeeze in another question. The next one is, for those institutions that had shorter LOS, do they have
Mm-hmm.
standard feeding practices as it pertains to breastfeeding and breast milk feeds? And if so, have they published their results?
That's a great question, and I have no idea, and they definitely have not published their results because I have not seen anything about that. Yeah, I don't know which NPC-QIC sites have specific. I actually don't know. I'm trying to think if I know of any specific human milk and breastfeeding feeding protocols. There are many, preoperative, postoperative feeding protocols that talk about human milk, particularly, not so much direct breastfeeding that I know of, but they're not focused on those things. So that would be another really interesting question to have answered.
Okay, thank you for
And if somebody
that.
knows of something, yeah, if somebody knows of something, please send it my way.
Definitely. Let's go ahead and try to squeeze in one more question before we end. What do you think are some of the next steps in terms of research in this area?
Yeah, so well, we just talked about a lot of them that people brought up. There's a lot that we know in preterm infants that we don't have not been explored in CHD infants. I think the first one is that we need to look at the more granular feeding data. So, these infants do often get fortified. We don't really know how that impacts them. There is the RCT that maybe some of you are familiar with that just came out on exclusive human milk, a new human milk derived fortifier for the cardiac population. So that is something that potentially may be on the horizon. But I think looking at specific doses and the response for these infants, also looking at the impact of all of these types of feeding on the gut microbiome and how it impacts outcomes, I think is important. And identifying what sites, those sites that are doing very well with above average prevalence, what are they doing to get these good results? I think those could all be important questions to answer next.
Thank you so much. And looks like we're almost at the top of the hour. So again, Kristen, thank you for presenting this today for us. And thank you everyone for
Mhm.
joining us for our webinar. Just a quick reminder, certificates will be available this Friday by logging into your account. And once we end the webinar today, a separate window will open up with an evaluation. So we'd love to have you take the time to fill that out so we can have our feedback. And you can visit medilaeducation.com to register for the up and coming webinars to the end of the year. And also, we're excited to announce that you can now subscribe to our Leading Lactation Insights monthly newsletter. And this is a newsletter that's put out monthly, which features factual and scientific information with no product promotion. And it covers cutting edge breastfeeding and lactation research, clinical news, and expert insights for IBCLCs, lactation consultants, and also maternal health professionals just like yourselves. So thank you again, and I hope everyone has a great afternoon.